Hi, everyone. It's Andrew Penn, clinical professor at UCSF. This is a short module to go over a new medication that was recently approved by the FDA, known as Xanomeline. I'm not even sure I'm pronouncing it totally correctly, combined with trospium chloride. The brand name is Cobenfy. And this is a new antipsychotic medication, the first medication approved in, I think, about 60 years for psychosis that doesn't actually work, at least partially, on by blocking postsynaptic dopamine receptors. It does modify dopamine. That's sort of a short take-home message, but not by blocking postsynaptic receptors. So if you stay with me, that will hopefully make sense by the end of this. I put these slides together sort of really for my own learning. And so they might be a little bit clunky. I don't have any vested interests in this medication, and conflicts of interest. So just a quick reminder that historically, the way we've treated psychosis, schizophrenia, is by blocking postsynaptic dopamine receptors. And so the areas that we're mostly interested in blocking are these things such as the ventral tegmental area, but dopamine, as you recall, plays a lot of different roles in bodily function outside of just psychosis. Involves things like pleasure, movement, and lactation. And mostly what we've done in the past is that we've blocked these postsynaptic dopamine receptors. Primarily, we've been targeting in the last 30 years or so, trying to focus mostly on D2, which is what separated the first generation of antipsychotics from the second generation. The first generation being more non-specific, blocking all the dopamine receptors, and also that the second generation or atypical antipsychotics also block serotonin 2A, which is an attempt to release dopamine in areas of the brain where we need it while trying to block dopamine in areas that it's thought to be overactive. So just a quick reminder that there are these four dopamine pathways in the brain. In psychosis, we're mostly targeting what is known as the striatal or mesolimbic area. This originates in the ventral tegmental area, and this is where we register a reward, but when overactive, either in schizophrenia or, say, in methamphetamine psychosis, we see this sort of psychotic symptoms emerge. We want dopamine activity in the mesocortical regions because that is partially responsible for mediating cognition. And it's that serotonin 2A blockade with the atypical antipsychotics that is hoping to increase dopamine in that area. And then, of course, we have these sort of non-psychiatric issues, but that obviously fall in our domain when we cause them as side effects, and that's blockade of dopamine in the nigrostriatal area, which will cause these movement disorders such as pseudoparkinsonianism and also what are known as extrapyramidal symptoms or EPS. And then blockade in the tuboinfundibular tract causes prolactin to be released, which can lead to gynecomastia and galactorrhea. So this is all the challenges with blocking dopamine. And so we get some benefit by blocking those striatal areas, but we also cause these side effects by blocking it in areas that we don't want. And obviously atypical antipsychotics have been an attempt to kind of mediate some of that dopamine blockade, but obviously are imperfect because they still come with symptoms. So remembering that we're trying to block that mesolimbic striatal pathway to reduce those positive symptoms, but blocking it in the nigrostriatal pathway causes those extrapyramidal pseudoparkinsonian type symptoms, and that blocking it in the tuboinfundibular tract causes that rise in prolactin. So these are all the side effects that come from blocking dopamine on postsynaptic receptors. So now we introduce acetylcholine. So acetylcholine, we don't normally think of that much when we think about psychosis, other than managing some of those movement side effects. We often give anticholinergic drugs, and that comes with its own set of side effects. But acetylcholine, as you recall, is a whole nother neurotransmitter system. It is the primary neurotransmitter of the parasympathetic nervous system. And there are two types of receptors, so nicotinic and muscarinic. Going to mostly focus on muscarinic, which are abbreviated MAH. MAHC. AHC stands for acetylcholine, and the small case M stands for muscarinic. So we've got those nicotinic receptors, which we're not really going to talk about. Those are activated by nicotine. And then you've got muscarinic receptors, which are a different type of receptors. So the nicotinic receptors are those ion channels. So when they're activated, positively charged ions can flow in. You recall that from the beginning part of this course. And these muscarinic receptors are G-coupled protein receptors. So when they are activated by acetylcholine, it causes that secondary stream of events that happens inside the cell as that G protein is moved and downstream effects happen. Now, they're called muscarinic receptors because muscarine attaches to them more readily than nicotine. And there are five types. So we're mostly going to be focusing on M1 and M4. Now, let's remember the autonomic nervous system. So you've got the parasympathetic nervous system, which is kind of your rest and digest, primarily mediated by acetylcholine. And then you've got your sympathetic nervous system, which is your fight or flight, primarily activated by norepinephrine. So we have to think a little bit backwards here. So when we go ahead and block the acetylcholine receptors with anticholinergic drugs, right? What are the symptoms that we see? This is kind of a classic boards question, right? So we would see things like blurry vision because we are now creating a dominant tone of the sympathetic nervous system because we're blocking those acetylcholine receptors, which are largely responsible for mediating the parasympathetic nervous system. So when we think about this, it actually kind of those classic symptoms that we would regurgitate for a board exam of what are anticholinergic side effects, right? Diarrhea, sorry, not diarrhea, constipation, dry mouth, blurry vision, those urinary retention, it all makes sense now, right? Because we're blocking acetylcholine, which means the sympathetic side of the equation is going to predominate. We're going to see those symptoms like blurry vision, dry mouth, tachycardia is another one, because again, sympathetic nervous system is predominating. Gastroparesis, because we're blocking that stimulating effect of the stomach when we block those acetylcholine receptors, constipation, urinary retention. Okay. Now, interestingly, the distribution of muscarinic receptors is more weighted for M1 and M4 in the CNS, in the central nervous system, whereas M2, M3, I'm not going to talk so much about M5 here, but M2 and M3 are mostly in the periphery. So when we think about some of those physiologic anticholinergic side effects, we see those in things like the gut, right? And you see here, there's a lot of M2 and M3 receptors in the gut, whereas the M1 and M4 receptors are mostly in the brain. They're in places in areas of the brain as listed here. And again, thinking about when we block acetylcholine receptors too much, we get into what is known as an anticholinergic toxidrome, right? So you probably remember this mnemonic: mad as a hatter, blind as a bat, red as a beet, hot as a hair, dry as a bone. So when we overactivate those anticholinergic receptors, we block them, sorry, not activate them, block them, we can get even an anticholinergic delirium, which has a sort of psychosis-like presentation. If we activate, or if we have agonists on acetylcholine receptors, we get this sort of wet presentation, right? People are urinating, they're having diarrhea, they might have tearfulness, they're overly salivating. So we can overactivate acetylcholine receptors in the periphery too, and that will cause an own set of problems. Now, I'm setting this all up here for you to understand how some of the side effects and why this medication is so intriguing, because by combining these two medications, one being a procholinergic agent and the other being an anticholinergic agent, we can mediate some of these issues. So some of the meds that we already use that act on acetylcholine, I mentioned the anticholinergic medications like benzotropine or cogentin. Obviously, I'm talking about Xanomeline and Trospium here, but also the anti-Alzheimer's drugs. So like donezepil is a anticholinesterase. Remember, when you hear ACE at the end of something, that implies an enzyme. So those drugs, they inhibit the enzyme that breaks down acetylcholine. So the idea is we're trying to give somebody who has Alzheimer's dementia more acetylcholine activity. So we inhibit the enzyme which breaks those down. They don't work very well, but that is one of the things that we try to treat them with. And then, of course, we normally think about acetylcholine as a problem when we're having those anticholinergic side effects that come from blocking these muscarinic receptors. So it was found that as long as 60 years ago that we could that if you overactivated those muscarinic acetylcholine, or if you I'm sorry, I keep misspeaking, if you block acetylcholine, anticholinergic effects, if you have too much of that activity, you can actually cause cognitive impairment, right? We've all seen that with somebody who's maybe on an anticholinergic drug who just feels really cognitively dulled. Or if you go too far, you can actually cause a delirium, psychosis-like symptoms. And so there was a sort of an accidental observation that so in some parts of the world, people choose something called betel nuts, and you can see it has this sort of red color. It tends to stain people's teeth, but that there's a compound in there called aracholine, sorry, that was observed to reduce psychosis symptoms in people that had schizophrenia who chewed betel nuts. And in the 1980s, xanomeline was explored to see if it could actually help with Alzheimer's dementia as a acetylcholine agonist. Could it help with dementia? Which makes sense given what we just talked about, how other ways of increasing acetylcholine availability have also been explored as treatments for dementia. And what was interesting was they had a surprise finding that people that had Alzheimer's, and it's not uncommon with Alzheimer's to have some symptoms of psychosis, that their psychosis got better. The problem was it gave these folks a lot of side effects. And knowing what you know about acetylcholine agonism, you can imagine what those would be. So they'd be things like GI distress and diarrhea. And that's what kept the drug developers from taking this any further. So it was kind of shelved in the 1980s. So this drug Cobenfy is really interesting because there's actually two drugs. They're combined in the same pill at a set ratio. Xanomeline or Xanomeline, I'm going to learn to pronounce this eventually, is a procholinergic drug. So it is a acetylcholine receptor agonist that can cross the blood-brain barrier and attach itself specifically to M1 and M4 receptors. However, remember, a drug doesn't know where it is in the body. If it sees one of those receptors, it's going to attach itself to it. And so if it's in the brain, great, that's going to do what we want. If it's in the gut, it's going to cause those procholinergic effects. So that was the limiting reason why this drug wasn't taken any further in the 1980s. So the really clever thing they've done here is they've combined it with something called trospium chloride, which is a anticholinergic drug that doesn't cross the blood-brain barrier. So you've got one drug that can be allowed in the brain, past the blood-brain barrier. We call that centrally acting. And then another one that doesn't cross the blood-brain barrier that is anticholinergic. And that's what we would call that peripherally acting. And the idea of adding trospium is to counteract those procholinergic effects in the periphery of xanomeline. And so we can start to think about what sort of side effects we might get from this and what kind of benefits we might get from this. So I'll talk about how xanomeline influences downstream dopamine release in a moment, but we might see some improved cognition. And then outside that anticholinergic and procholinergic kind of battle that's going to be happening in the periphery could cause things like GI distress, diarrhea, because that when we have acetylcholine blockade, that predominates the sympathetic nervous system. So we could see some tachycardia as the sympathetic nervous system is going to predominate with sympathetic tone on the heart. We might see things also like increased salivation, and the anticholinergic effects of trospium will cause sort of the standard anticholinergic problems like dry mouth, constipation, and blurry vision. So we can kind of anticipate that there's going to be this sort of battle in the periphery between this procholinergic and anticholinergic side effects. And when we take a look at the prescribing information and see what were the most common side effects, nausea, dyspepsia, vomiting, diarrhea, all were more common on Cobenfy, on this combination of drugs, than they were on the placebo. And then we also see the effects of the anticholinergic. So constipation was more common in the Cobenfy group, dry mouth, blurry vision. So there's this kind of battle that's happening in the periphery while we're trying to get this procholinergic drug across the blood-brain barrier. Now, what's interesting about this Cobenfy drug is that it does not block postsynaptic dopamine receptors or serotonin 2A receptors. So it is not an atypical antipsychotic. It's important to understand that. It's an antipsychotic that has a totally different mechanism of action. And the benefit to that is that it should reduce some of those side effects that we see with dopamine, postsynaptic dopamine blockade, such as those movement side effects and lactation. It also appears that this drug is more metabolically neutral. The weight gain between the drug group and the placebo group was about the same. They each gained about 1.5 to 2 kilos. So even the placebo group gained weight. And we can also look at the pharmacodynamics of this and see that this is more sticky or has a lower Ki on the M1 and M4 receptors, which than it does on the M2 and M3 receptors. So this is really going to tell us where this drug is more likely to stick to. And remember that xanomeline can cross the blood-brain barrier and stick to these receptors inside the brain. Okay, so this is where it gets a little bit complicated, but bear with me. Might need to go through this a couple of times for this to make sense. I know I certainly did. But the too long didn't read here is that through an indirect route, we are reducing the amount of dopamine being released into those key areas for schizophrenia, such as the ventral tegmental area and the nucleus accumbens. Now, how we do that, bear with me here, and I'll go through this and try and point out each section here. But take a look at this slide here. I just want to orient you for a second. So this would be a frontal cortex neuron, this purple area, which is synapsing onto one of these ventral tegmental area dopamine neurons. So in the cortex, we have these, you remember from our early lessons, we talked about glutamate being the primary excitatory neuron and GABA being the primary inhibitory neuron. And remember that GABA largely has this inhibitory effect through these interneurons. So what you see here is a GABA interneuron synapsing onto an excitatory glutamate neuron. That glutamate neuron now downstream is going to excite this dopamine neuron. So I want to point out a couple of things here. There is an M1 receptor on the GABA interneuron. And that's going to, if we can activate that GABA interneuron, it's going to inhibit the activity of this glutamatergic excitatory neuron, which is then going to reduce the amount of signal going to that dopamine neuron. So let's walk through this again. So we've got those we have glutamatergic or glutamate excitatory neurons that are synapsing onto those dopamine neurons in the ventral tegmental area. That VTA is a key area for psychosis. And then we've got those upstream GABA inhibitory neurons that are synapsing onto the glutamate neurons. So they're sort of acting kind of like brakes, right? And there's these M1 receptors, these muscarinic 1 receptors on the GABA interneuron. So think about that. When we activate these, what are we doing? So we're activating this with a procholinergic, specifically an M1 agonist on that GABA interneuron. So by activating that GABA interneuron, we are slowing down, we're hitting the brakes a little bit for that glutamate neuron that it synapses onto, which is then going to not excite that downstream ventral tegmental area dopamine neuron. It's a lot to take in. You might want to go back and revisit this a couple of times. I know I certainly needed to do that. So that's route 1. And now what about route 2? What about those so that M4 activation? So acetylcholine is going to activate the release of dopamine into that ventral tegmental area and the nucleus accumbens, right? So we've talked about that, how acetylcholine is going to activate dopamine release. This is actually a second mechanism, so this is separate from what we just went through. But again, the TLDR is that we are decreasing the amount of dopamine being released in these key midbrain areas as the nucleus accumbens and the ventral tegmental area, but not by blocking the dopamine on that postsynaptic side. So the interesting thing here is that in the ventral tegmental area, the acetylcholine M4 receptor is actually an autoreceptor. So remember, autoreceptors act sort of like your thermostat in your house. They tell the heater that the room is now hot enough and it can stop releasing heat. In the nervous system, those autoreceptors pick up the neurotransmitter that they are coded for. So in this case, acetylcholine. And when they're activated, they say, hey, you don't need to release so much of that neurotransmitter anymore. So when that M4 autoreceptor is activated by xanomeline, what's going to happen is that it's going to trick that acetylcholine receptor into not releasing so much acetylcholine. Why do we care about that? Well, it's that acetylcholine that is, which is activating the dopamine neuron. So by having less acetylcholine, we have less excitation of that dopamine neuron. And that's a good thing because we're trying to decrease the amount of dopamine activity in these midbrain areas in order to control the symptoms of psychosis. Now, in the nucleus accumbens, this neighboring area of the midbrain, there are those interneurons, but this time these are acetylcholine interneurons. And you'll notice right up here, there's an M4 receptor on them. So when we activate that M4 receptor, then again, we have less of that downstream acetylcholine excitation to the dopamine neuron, resulting in less dopamine release. So the bottom line is by manipulating acetylcholine through these two different pathways, we are able to decrease how much dopamine is released downstream, which is pretty darn clever. So the bottom line is that we get to reduce the amount of dopamine being released without having to block those postsynaptic dopamine receptors. Now, of course, the proof of any medication is always in the pudding, right? Does it actually work? And this is the PANSS, a pretty common way of scoring. There's a positive and a negative scale. And now, when I first heard about this med, I thought, oh, acetylcholine and psychosis, cognition, this is probably for like negative symptoms, right? And it turns out that that's actually not true. But which, now that we know that the endpoint mechanism of this drug is to decrease the amount of dopamine that's being released, it actually makes sense that this would reduce positive symptoms as well as negative ones. So what you see here is the placebo arm, that dark blue, and then the xanomeline and trospium group down here. And we're seeing, a couple of 3 weeks before we really start to see separation of signal. So again, this is not going to be something that you necessarily see benefit with right away. It's going to take a few weeks. But at the endpoint at 5 weeks, there was considerable separation between these two groups for both the combined and teasing out both positive and negative symptoms. So, pretty impressive. They did a continuation study where the group of people that were in the placebo group were crossed over and they were given Cobenfy, or what was called in its development stage CAR-XT, and continued on. And what's interesting is you can see the folks. So this is any treatment emergent adverse event that occurred during that 52-week period. And so you can see the folks that had already kind of gotten used to the med had sorry, that would be this blue group over here, had fewer of these side effects once they were kind of up to speed. So this would seem to be the kind of things that we're going to be warning people about as they start this medication, particularly GI stuff, nausea and vomiting, dyspepsia, which is just upset stomach, right? And then the anticholinergic things from dry mouth, constipation, things like that. So, but it seems like once you've been on the medication for a while, those things become less of an issue. I think that's what we can kind of glean from this information. This drug is going to come in 3 different strengths. The challenge with all combination meds is that you're stuck with that combination. So you can't have a 10 milligram trospium capsule. It doesn't come in one. So we got to work with what we have here. But the dosing instructions and the prescribing information are to start with this 50 milligram of xanomeline with 20 milligrams of trospium for it's a BID dosing, has a fairly short half-life, about 5 or 6 hour elimination half-life. So it needs to be dosed twice a day, which is kind of a drag, but that's dictated by the pharmacokinetics of the drug. And then you can increase after a couple of days if the person's tolerating it, you go to this 100 to 20, and then the maximum dose is 125 and 30 respectively twice a day. It is largely processed through 2D6 and 2B6 with lesser on 1A2, 2C9, and 2C19. And when we're starting people on this, the prescribing information says that we need to monitor for urinary retention and constipation, which certainly makes sense. Also worsening glaucoma. Those would be all be symptoms that go along in addition to tachycardia with the anticholinergic side effects in the periphery, in addition to dizziness and sedation. There is a warning around angioedema and hepatic issues. We're instructed in the prescribing information to get LFTs before starting this medication and then monitoring that. Interestingly, this medication, because it is not a classic antipsychotic or an atypical antipsychotic, it doesn't have that black box warning that all the antipsychotics have around use in dementia. And given its history of being able to have some benefit in Alzheimer's psychosis, while it's not labeled for that, I could definitely see there potentially being some possible benefit down the road. And I know that there's active investigation into that right now. It's not cheap. Most branded antipsychotics are not. It's running just shy of $2,000 a month. I don't think it's actually quite yet, as of me recording this in mid-October 2024, available in pharmacies, but I think that should change fairly soon. And, we don't really know exactly where this is going to fall in our treatment algorithms. Is this going to be a first-line medication? Is this going to be a second line? Is this going to be combined with dopamine blocking drugs? I know most of us clinically tend to be fairly conservative with our patients with schizophrenia just because of the risks and the perils of poorly treated schizophrenia. And so I would imagine that the naturalistic use of this medication in clinical populations will probably start out as combination therapy with dopamine blocking drugs. So it'll be interesting to see how the sort of clinical use of this drug changes over time. Again, don't know where this is going to fall under insurance. And, the tolerability issues are really somewhat different than our previous antipsychotic medications, those dopamine blocking drugs. And so for some people that are sensitive to GI distress, that may be a deal breaker with this medication. And it'll be interesting to see if in clinical use there are kind of mitigating strategies. Like, I have no idea, for example, if something like Zofran would be helpful to mitigate the nausea with this drug. I don't think anybody's looked at that. In the future, there are a number of other M1, M4 agonists that are in the pipeline. People that I know that are in the drug development space really feel like this may very well be the future of schizophrenia treatment. We'll see if that kind of enthusiasm actually is followed up with additional drugs. It's likely that we'll see M1 and M4 specific agonists, so maybe not having the two together, maybe only having one or the other. But definitely I think this is a space worth watching, and it's interesting enough that I wanted to share what I've learned with you and kind of teaching myself about this, which is honestly how I learn about most things is teaching it so that I can teach it to other people. So I hope you found this useful, and look forward to hearing any questions that you have. Thanks. Bye.